Welcome to Pediatric Case Review. Today's lecture covers idiopathic thrombocytopenic purpura in children, an important hematologic disorder you'll encounter in clinical practice. We'll explore its presentation, diagnosis, and evidence-based management through case-based scenarios. Let's start with epidemiology. A 4-year-old previously healthy girl presents with sudden onset petechiae and bruising. Which of the following statements about childhood idiopathic thrombocytopenic purpura is correct? A. It affects boys more commonly than girls. B. Peak incidence occurs between 2 to 5 years of age. C. Most cases follow bacterial infections. D. It typically affects older children and adolescents. The correct answer is B. Pediatric idiopathic thrombocytopenic purpura has a peak incidence between 2 to 5 years of age. Unlike adult ITP, childhood IDP affects boys and girls equally. The annual incidence is 4 to 8 cases per 100,000 children, and many cases follow viral infections, typically occurring 1 to 4 weeks after the infectious illness. Now let's explore the pathophysiology. What is the primary mechanism of thrombocytopenia in childhood idiopathic thrombocytopenic purpura? A. Decreased platelet production in bone marrow. B. Immune-mediated platelet destruction. C. Splenic sequestration of platelets. D. Congenital platelet dysfunction. The correct answer is B. The primary mechanism in ITP is immune-mediated destruction of platelets. Autoantibodies, primarily immunoglobulin G, bind to platelet membrane glycoproteins. These antibody-coated platelets are then recognized and destroyed by macrophages in the reticuloendothelial system, particularly in the spleen. Bone marrow examination typically shows normal or increased megakaryocytes, confirming normal platelet production. Let's discuss clinical presentation. A 3-year-old boy develops multiple bruises and a petechial rash over his trunk and extremities 2 weeks after a viral illness. He is otherwise active and well-appearing. Which presenting feature is least likely in this patient? A. Epistaxis. B. Gingival bleeding. C. Joint pain and swelling. D. Isolated skin manifestations. The correct answer is C. Joint pain and swelling are not typical features of idiopathic thrombocytopenic purpura and should prompt consideration of alternative diagnoses like leukemia or juvenile idiopathic arthritis. Classic IDP presents with petechiae, ecchymosis, and sometimes mucosal bleeding like epistaxis or gingival bleeding. Most children with IDP appear otherwise healthy and active, with bleeding manifestations being their only abnormality. Continuing with clinical presentation, a 5-year-old girl presents with widespread petechiae and bruising. Which bleeding manifestation is most concerning and would warrant immediate intervention? A. Small petechiae around ankles. B. Wet purpura, which refers to oral mucosal bleeding. C. Large bruise on thigh. D. Epistaxis that stopped after 5 minutes. The correct answer is B. Wet purpura, or bleeding from mucous membranes in the mouth, is associated with an increased risk of serious bleeding, including intracranial hemorrhage. This finding warrants immediate attention and often treatment. In contrast, skin-only manifestations like petechiae or bruising, even if extensive, generally indicate a more favorable prognosis. This is why careful examination of mucous membranes is critical in the assessment of children with suspected IDP. Moving to physical examination findings. During examination of a 4-year-old with suspected idiopathic thrombocytopenic purpura, which finding would be unexpected and suggest an alternative diagnosis? A. Scattered petechiae and ecchymosis. B. Hepatosplenomegaly. C. Normal growth parameters. D. Absence of lymphadenopathy. The correct answer is B. Hepatosplenomegaly is not expected in idiopathic thrombocytopenic purpura and should prompt consideration of alternative diagnoses such as leukemia, lymphoma, or infectious causes of thrombocytopenia. In typical IDP, the physical examination is normal except for bleeding manifestations like petechiae and bruising. Children with ITP typically have normal growth parameters and no lymphadenopathy, supporting the diagnosis of an isolated platelet disorder. Continuing with examination findings, which physical examination finding is most strongly associated with increased risk of intracranial hemorrhage in pediatric idiopathic thrombocytopenic purpura? A. Petechiae on the face. B. Retinal hemorrhages. C. Bruising on the extremities. D. Petechiae on the trunk. The correct answer is B. Retinal hemorrhages may precede or accompany intracranial hemorrhage and represent a serious warning sign. Fundoscopic examination should be performed in children with severe thrombocytopenia, especially those with headache or neurological symptoms. While cutaneous manifestations like petechiae and bruising are common in IDP, they alone don't strongly predict the risk of intracranial hemorrhage, which occurs in less than 1% of pediatric IDP cases. Let's move on to investigations. A 6-year-old presents with isolated thrombocytopenia with a platelet count of 15,000 per microliter in purpura. Which investigation is most important in the initial evaluation? A. Bone marrow aspiration. B. Complete blood count with peripheral smear. C. Platelet antibody testing. D. Head CT scan. The correct answer is B. A complete blood count with peripheral smear is the most important initial investigation. IDP is characterized by isolated thrombocytopenia with otherwise normal blood counts. The peripheral smear can exclude pseudothrombocytopenia and reveal abnormal cell morphology, suggesting alternative diagnoses like leukemia. Bone marrow examination is not routinely needed in typical IDP presentations, but may be considered with atypical features. Platelet antibody testing lacks sensitivity and specificity, while head CT is only indicated with neurological symptoms. Continuing with diagnostic investigations, which laboratory finding would make the diagnosis of idiopathic thrombocytopenic purpura less likely? A. Platelet count of 12,000 per microliter. B. Large platelets on peripheral smear. C. Leukopenia with neutropenia. D. Negative ANA test. The correct answer is C. Leukopenia with neutropenia suggests a diagnosis other than idiopathic thrombocytopenic purpura, such as bone marrow failure, leukemia, or systemic lupus erythematosus. IDP is characterized by isolated thrombocytopenia with normal white blood cell and hemoglobin levels. Large platelets are typically seen on peripheral smear in IDP, representing young platelets released from the bone marrow in response to peripheral destruction. A negative ANA test would be expected in primary IDP. Regarding bone marrow studies, a 7-year-old boy with suspected idiopathic thrombocytopenic purpura has a platelet count of 10,000 per microliter but is otherwise well with minimal bruising. When is bone marrow examination indicated? A. Always required to confirm IDP diagnosis. B. Only if there are abnormalities in other cell lines. C. Only before starting corticosteroid treatment. D. Only if the platelet count is less than 10,000 per microliter. The correct answer is B. Bone marrow examination is indicated in suspected idiopathic thrombocytopenic purpura only when there are atypical features, such as abnormalities in other cell lines, suggesting an alternative diagnosis like leukemia. Current guidelines do not support routine bone marrow examination in children with typical features of IDP. Other indications might include atypical clinical features, failure to respond to first-line therapy, or consideration of second-line treatments. The absolute platelet count alone is not an indication. Moving to treatment. A 5-year-old girl presents with newly diagnosed idiopathic thrombocytopenic purpura, platelet count 25,000 per microliter, and minimal petechiae. She is otherwise well. What is the most appropriate initial management? A. Immediate IVIG administration. B. Start prednisone at 2 mg per kilogram per day. C. Observation with close follow-up. D. Platelet transfusion. The correct answer is C. For a child with minimal bleeding symptoms and no significant risk factors, observation with close follow-up is the preferred initial approach, regardless of the platelet count. This is supported by current guidelines recognizing that approximately 80% of pediatric idiopathic thrombocytopenic purpura cases resolve spontaneously within 6 to 12 months. Treatment is indicated primarily for significant bleeding or high bleeding risk, not based on platelet count alone. Platelet transfusions are generally avoided unless there is life-threatening bleeding. Regarding treatment options, which treatment provides the most rapid increase in platelet count for a child with idiopathic thrombocytopenic purpura and significant mucosal bleeding? A. Oral prednisone. B. Intravenous immunoglobulin or IVIG. C. Anti-D immunoglobulin. D. Rituximab. The correct answer is B. Intravenous immunoglobulin provides the most rapid increase in platelet count, usually within 24 to 48 hours, making it the treatment of choice for children with significant bleeding. The typical dose is 0.8 to 1 gram per kilogram as a single infusion. In comparison, corticosteroids typically take 3 to 5 days to significantly increase the platelet count. Anti-D immunoglobulin works faster than steroids, but slower than IVIG, while rituximab may take weeks for effect and is reserved for chronic cases. For chronic IDP management, an 8-year-old with chronic idiopathic thrombocytopenic purpura, 18 months duration, has a platelet count of 20,000 per microliter with occasional bruising. What is the most appropriate management approach? A. Splenectomy. B. Thrombopoietin receptor agonist. C. Observation if quality of life is good. D. Maintenance corticosteroids. The correct answer is C. For children with chronic idiopathic thrombocytopenic purpura who have minimal bleeding and good quality of life, observation remains the preferred approach regardless of the platelet count. The goal of management is to prevent significant bleeding while minimizing treatment-related side effects. Splenectomy is rarely performed in children and delayed until at least 5 years of age if absolutely necessary. Thrombopoietin receptor agonists may be considered for severe chronic IDP with significant bleeding. Long-term corticosteroids should be avoided due to significant side effects. Moving to complications, what is the most serious potential complication of pediatric idiopathic thrombocytopenic purpura? A. Splenomegaly. B. Intracranial hemorrhage. C. Iron deficiency anemia. D. Recurrent infections. The correct answer is B. Intracranial hemorrhage is the most serious potential complication of pediatric idiopathic thrombocytopenic purpura, though fortunately rare, occurring in less than 1% of cases. Risk factors include severe thrombocytopenia, especially platelets less than 10,000, presence of mucosal bleeding, and head trauma. When intracranial hemorrhage does occur, it carries a mortality rate of 1 to 5%. This risk underlies the importance of activity restrictions and close monitoring in children with severe thrombocytopenia. Regarding associated conditions, which condition is most commonly associated with secondary idiopathic thrombocytopenic purpura in children? A. Systemic lupus erythematosus. B. HIV infection. C. Lymphoma. D. Recent viral illness. The correct answer is D. Recent viral illness is the most common association with childhood idiopathic thrombocytopenic purpura, with symptoms typically developing 1 to 4 weeks after the infection. Common viral triggers include Epstein-Barr virus, cytomegalovirus, parvovirus, influenza, and varicella. While systemic lupus erythematosus can cause secondary IDP, it's more common in adolescents and adults than in young children. HIV-associated thrombocytopenia is important to consider in at-risk populations, while lymphoma-associated IDP is relatively rare in children. Regarding activity restrictions, a 6-year-old with idiopathic thrombocytopenic purpura has a platelet count of 35,000 per microliter. Which activity recommendation is most appropriate? A. No restrictions are necessary. B. Avoid contact sports only. C. Restrict all physical activities. D. Complete bed rest. The correct answer is B. For a child with a platelet count of 35,000 per microliter, avoiding contact sports and high-risk activities for head trauma is appropriate, while allowing other normal activities. Activity restrictions should be individualized based on the child's platelet count, bleeding history, developmental stage, and lifestyle. Complete restriction of all activities or bed rest is rarely warranted and may negatively impact quality of life. As the platelet count rises above 50,000, most activity restrictions can be lifted, though extremely high-risk activities may still be avoided until counts normalize. Thank you for joining this pediatric case review lecture on idiopathic thrombocytopenic purpura in children. Remember that ITP is primarily a diagnosis of exclusion characterized by isolated thrombocytopenia. Management should focus on bleeding symptoms rather than platelet count alone, and most cases resolve spontaneously. Please subscribe to our pediatric case review channel for more educational content, and leave your questions in the comments section below. We look forward to seeing you in our next presentation.